Hi, this is Herb Chase, and we're going to talk about data mining today. Data mining and machine learning. We have several learning objectives we'd like to achieve in this podcast. First, after the podcast, you should be able to define data mining. You should also be able to describe different machine learning approaches. We're going to talk about supervised machine learning, where we, the human, tells the computer what to do. And we're going to talk about unsupervised learning, where the computer tells us what is important. You should be able to provide examples of each approach. And lastly, we're going to focus on the limitations of data mining and machine learning. There's been an explosion, as you've no doubt heard and read about in newspapers. It's unavoidable that data mining has exploded because of the availability of data in every single domain on the planet Earth, and especially importantly in healthcare. There are massive amounts of data available. Obviously, there can be no legitimate data mining without a lot of data. A single patient, for example, will have thousands of patient data points, and imagine tens of thousands of patients with their thousands of data points. So there's a tremendous amount of information. There have been major advances in computational processing. The hardware has grown exponentially. The software can extract, store, and analyze huge amounts of data. This was not true until very recently, that we had the software and the hardware to accomplish these goals. And lastly, there have been significant breakthroughs in machine learning. There are new algorithms that are rapidly advancing our understanding of health and disease. There are ways to approach the data and extract new information. We're going to talk a little bit about how to probe the databases, and then we'll move on to specific examples. First and foremost, you need to start off with a data set of whatever the data is you're looking at. In healthcare, we have particular kinds of data. And the data must be extracted. If all the data, for example, is in the electronic health record, stored in various locations in various ways, that data must be extracted and processed so that it can be analyzed by a computer. Maybe all the data will be extracted and put in several spreadsheets. That is easily computable. Maybe the data will be words that need to be converted into computable data and then put into a spreadsheet. Then once the data has been extracted and processed, algorithms are used to derive new information. As mentioned, the algorithms can be supervised or unsupervised, and we'll talk more about that later. Now, let's start with supervised learning, where the human tells the machine what's important. So one of the classic supervised learning algorithms is classification. Can a machine correctly identify, for example, a patient with a disease from a patient without a disease? Can a machine identify patients who have high blood pressure from those who don't have high blood pressure? And the point here is you train the machine to figure out what the attributes are of someone with a disease and without the disease, and then see if the machine can figure out how to do it on its own. Another example of supervised that we'll talk about in a second is prediction modeling. Can you generate a model that will make some predictions based on the patient's status? Whatever the blood tests reveal or their vital signs, can the machine come up with a model to make a prediction? Let's talk first about classification and ask, could we build a machine to identify patients with multiple sclerosis, which is a serious neurological disease? Could they identify patients with multiple sclerosis from the notes in the patient's electronic health record? Now, built in the notes, somewhere in the notes, a patient with multiple sclerosis is going to complain of various signs and symptoms. They might say they're weak, which we call paresis. They might have double vision or diplopia. They may have numbness in one or more of the body parts. And for example, maybe they have migraine headaches. These are all subtle, some major, some minor signs of multiple sclerosis. So imagine a machine actually making a model, a classification model, based on those signs and symptoms. Now, as mentioned, any words in the electronic health record have to be converted to some computable data, and in this case we would use natural language processing to map those terms to a terminology where a computer could then use algorithms to identify which of the terms are more important than others. I'm sure there are podcasts galore on natural language processing, and you can go out and search and find one of those if you're interested. We then asked the machine to create a model, a diagnostic classifier that will learn and figure out which patients have multiple sclerosis, i.e., which of them have those signs and symptoms, from those patients without multiple sclerosis. And if the classifier can do a good enough job, and maybe the positive predictive value is high, that is, the probability of having multiple sclerosis in anybody walking off the street would be low, but the machine may say, wow, based on those signs and symptoms, there's a much higher probability to have multiple sclerosis. If the positive predictive value is high enough, then the machine can notify the provider of the electronic health record. So how would you go about building this classifier? First, we create a database where we made of patients with multiple sclerosis, and we identify signs and symptoms or attributes that we think are important in terms of identifying patients with multiple sclerosis. As I just mentioned, maybe diplopia, migraine headaches could be symptom number 2. Symptom number 3 could be numbness and tingling. Symptom number 4 could be weakness. And each patient, we record whether or not the patient had that symptom or not. Then we create another database of patients without multiple sclerosis of similar age and gender, and some of those patients are going to have migraine headaches. These are patients without multiple sclerosis, and some of them are going to have double vision. And we do the same. We fill in which of the patients have a positive history of those signs and symptoms. And then we have the machine train. The machine is training on data that we've provided the machine, and it is supervised. We're saying to the machine, look, these people have multiple sclerosis, and these people don't. So the machine trains on that and identifies which values are important. Perhaps a migraine headache will end up not being important. It's just too vague, it's too common in people without multiple sclerosis. And the machine says multiple sclerosis is not going to be, the diagnosis is not going to be helped, facilitated by looking at migraine headache. So the machine develops a model based on these signs and symptoms and tries to come up with a way to accurately separate the patients with multiple sclerosis from those who do not have it. And then with the model, one tests on a new set of patients on whom it is not known, which of them have multiple sclerosis. And based on this new set, the machine can develop a sensitivity and specificity which will help identify, yield a positive predictive, negative predictive value. So this is how we would make a classifier for multiple sclerosis. Again, it's supervised. We told the machine what signs and symptoms we think are important. We published this work several years ago, and I just point this out to show you that many students work on projects such as these. We had a fourth-year medical student, Lindsay, who's now graduated, and we have a couple undergraduates from Columbia who are now in finance and in Amazon. There are other examples of supervised training, which I'll show you in a second, but the key is that the machine has to train on a gold standard, on data which is supplied by us. And the attribute selection, which of those signs and symptoms are important, will be decided by the machine. As mentioned, maybe migraine headache will not be a useful attribute. Then, as also mentioned, the model has to be tested finally on a new set of data. Now let's look at another example of classification. This was an outstanding piece of work by a team that asked, could a machine identify patients with diabetic retinopathy? Does every patient with diabetes have to be sent to an ophthalmologist, which is usually the case, to see if they have diabetic retinopathy? Or could the machine say, well, out of these 100 patients with diabetes, only 10 of them have some retinal findings that might be consistent with retinopathy. And they trained on patients with and without diabetic retinopathy, and the statistics were outstanding. They trained on 120,000 retinal images. There was a lot of manual review by the physicians to make sure the machine got it right. And as a result of this, it was concluded that a machine was actually pretty good at figuring out which patients should get a consultation with an ophthalmologist and which patients did not need the consultation. Another example of classification, supervised classification. The modeling that the machine uses to classify, many algorithms that can be used: naive Bayes rules, logistic regression, and I just mentioned WECA, which is a suite of algorithms for just this purpose. They're free algorithms. WECA is from the University in New Zealand. You can download the package in 10 seconds, and it's very useful for classification tasks. Now let's move on to supervised learning and talk about prediction. Once again, the human says, well, we think these things are important. Cholesterol, in terms of predicting cardiovascular disease, cardiac heart disease, blood pressure, diabetes, smoking. And this is the Framingham risk score. You can go onto the web, you can plug these numbers in, and you can see what the likelihood of you having a cardiac event is over the next 10 years or so, whatever the time period is. And you can see that it's limited. There are only, 7 attributes: age, blood pressure. These are important. We've known that these are important attributes for years. But it's conceivable that there are other attributes that are important that have not been included in this model. So one of my colleagues, I'll show you her picture in a second, Noemi El-Haddad, performed a study with their colleagues where they looked at 300,000 patients. They knew what the outcome was. That's the supervised aspect here. They knew that which patients had coronary heart disease. And they looked at many different attributes. Now we're getting into the unsupervised phase here, where they said to the machine, the human said, well, look, here are some attributes. We don't know if they're going to make a difference, so why don't you take a look to see if they can be predictive in some way of coronary heart disease. They looked at vital signs, laboratory tests, medication orders, diagnoses codes from comorbidities, not just diabetes, but maybe chronic kidney disease is a predictor of coronary heart disease. And the machine identified new attributes. And again, this gets us into the unsupervised realm. The machine figured out that there were some predictive attributes that we humans hadn't anticipated. Here's Noemi El-Haddad. It's a fabulous study, and basically using the deep survival analysis algorithm, where they used many different attributes and trained on all those things I just mentioned, all those attributes, they had a better risk score than the Framingham study. Some of the risks are not as powerful. If your cholesterol is very high, that's a very powerful risk predictor. But maybe if your cholesterol is not that high and you also have chronic kidney disease and congestive heart failure and you've got chronic obstructive pulmonary disease, they may have less predictive power, but they're nevertheless predictive. So this is a great example, I think, of prediction and using machine learning to improve the predictive modeling. There was a study recently in PLOS 1 which basically asked the same question: could you look at routine clinical data and come up with a better model? And they concluded that the answer is yes, it does improve cardiovascular risk prediction. And what's interesting, it identifies, it demonstrates some inconsistency and demonstrates also the fact that there's some well-known predictors that are not included in the traditional risk score. So diabetes, as we've mentioned, is a classic. It's in Framingham. It's in the algorithms for the American Heart Association, and was also used in this machine learning algorithm. But the machine also identified chronic kidney disease, which practitioners have known for years are a risk factor for coronary heart disease or coronary artery disease, and it is not included in the Framingham risk prediction model. So once again, data mining and machine learning is very successful in creating models for prediction, which will become all the more important as we accumulate more data. So to summarize, we had supervised, and now we're going to have we're going to approach unsupervised learning. And there are two classic unsupervised approaches. There's finding associations, where the machine looks for two attributes that are associated, having no a priori understanding of whether or not they're going to be associated. And clustering, where you look at heterogeneous individuals and ask, are there subgroups where the subgroup has similar qualities and attributes that can be distinguished from other subgroups? And we'll talk more about the clustering in a second. So it looks for associations. So, one of my favorite associations to demonstrate is this one right here. This is my local supermarket where I have a house, and there's the beer dispenser, and there are limes there. Now, why on earth would limes be next to a beer dispenser? If you were coming in from another planet and landed in my supermarket, you'd wonder, why are limes there? And the answer, for those of you who are beer drinkers, is that many people put limes in their beer. Now, a machine can figure that out, and a machine figured out that people who bought beer also bought limes. Initially, limes were situated where they should be situated, which is in the fruit and vegetable section, which is far away from the beer section. But the machine, using association data mining, figured out that people who bought beer also bought limes, and so therefore the store owners hung a lime display right next to the beer association. This is classic associative data mining, unsupervised. I don't think people running the supermarket sat around and thought about doing this until they had the data. So what are some classic association studies? One very important one is identification of adverse events that are associated with medications. You get a large data set of patients who are on a particular medication or not, the control, and you ask, you also get all the signs and symptoms, and you ask the machine to say, look, are there any signs and symptoms that are associated with the drug specifically and that are not associated with the controls? Patients on this drug have that sign and symptom consistently and are associated, and patients not on the drug do not have this sign and symptom. So this is very important in terms of identifying previously unknown adverse events. The problem is that this kind of association is obviously confounded. For example, the machine might say, well, gee, insulin and diabetes are associated. Is diabetes a side effect of insulin? Well, of course not. We know that diabetes is treated with insulin. So if you find a diabetic retinopathy associated with insulin, the machine also has to be told, or it has to learn, that insulin is a treatment for diabetes. So there's some confounding issues which are challenging, but we'll worry about that later. So we look for drug-drug interactions, and I think one of the most interesting examples of associative unsupervised learning is looking at two drug adverse events. So in a study, which I'll show you Nick's picture in 1 second, the question was, are two drugs which have never been previously associated with a side effect capable of causing that side effect when given together? So he found, I'll show you in a second, two drugs, neither of which alone causes an elevated glucose, but do they when given together? And the answer is yes, the interaction could never have been predicted by what was previously known. then it was unknown. Drug A does not cause elevated glucose. Drug B doesn't cause an elevated glucose. But drug A and B together do cause an elevated glucose. And this is Nick Tatonetti. He's a brilliant young man who he's gone on. I'll show you another one of his studies in a second. But he found that two drugs, paroxetine and pravastatin, increases blood glucose levels. These are two commonly prescribed drugs. Neither one increases glucose alone, but together they do. This was another example of the drug-drug interactions. Again, drug A caused or resulted in normal cardiac conduction. Drug B, normal cardiac conduction. But then drug A and B together cause prolonged QT, which is associated with sudden death. So imagine a patient's taking drug A and then, for whatever reason, takes drug B. It's nowhere in the literature yet that these drugs can cause sudden death, but there is an association that was shown by classic unsupervised machine learning data mining. So here are two drugs that Nick identified. Prevacid is an over-the-counter medicine. You can walk into CVS and buy Prevacid. Ceftriaxone is a commonly used, totally benign cephalosporin antibiotic, much like penicillin. But when given together, there's a higher incidence or an association with prolonged QT, which, as mentioned, is a precursor to sudden death in some patients. So this is classic unsupervised learning. Let's give one other example, which is to ask, what drugs do we use to prescribe for various conditions? Do we choose the appropriate drug? Are they the least expensive? Do we follow guideline recommendations? This is very important for optimal patient care. So we asked the question here at our hospital, NYP, do we treat hypertension with the drugs we're supposed to treat hypertension with? And do we not use drugs for hypertension that we're not supposed to use? So we looked at several different conditions: congestive heart failure, coronary heart disease, diabetes, pregnancy, kidney failure. The green shows the drugs that we use preferentially, and it was quite reassuring that the bright green has a high association, positive association. And you can see that we treat drugs, congestive heart failure, with the appropriate drugs, ACE, A2 blockers and beta blockers, and we stay away. We use calcium channel blockers and thiazides much less frequently, which is appropriate. This is guideline-based. But even more importantly, I think, is that when patients are pregnant, we stay away from the drugs that they're not supposed to get, which are ACE inhibitors and A2 blockers, and we do give the drugs that they are supposed to get, which are the beta blockers and calcium channel blockers. This is all to say is that it's reassuring that here at NYP we follow the guidelines, and this study was conducted using data mining and unsupervised association. Let's move on and finish with clustering. Clustering is an interesting concept. You have a group of patients who all look more or less the same, and then you ask, well, wait a minute, are there subgroups there? In the years past, we would say, we took care of patients with diabetes, we say, well, that patient was diabetic, with diabetes was brittle, hard to control, insulin always was difficult, the glucose went up and down, it was very difficult to manage. And other patients were easy to control. Even if you gave them slightly more insulin than they should have gotten, they basically were fine. There are patients with chronic obstructive pulmonary disease. Clearly some had a constellation of symptoms that was different from others. And this is key. It does mean that one size doesn't fit all. It means that diabetes is a collage or a collection of many, many different kinds of diabetes. And this will be, of course, identifying these different patients, the different clusters will be critical in identifying the genetic basis of the disease. So this is classic clustering. Is there a way to identify these subgroups? And the answer is yes. You have used clustering algorithms. Again, you can find these on Weka. And what you need, of course, are large numbers of patients, thousands, with a record of attributes, yes or no, or what their blood pressure is, or diabetes, what's their glucose, or what other diseases they have, what other medicines they have, what's their family history, whatever attributes can be identified. And then the machine will try to cluster the various patients into subgroups, if they exist. As mentioned, this will lead the way to identifying the genetic basis. So there is one study, there are many studies out there, but I just showed you one, that the study of asthmatic patients. It ends up, not surprisingly, that asthmatics are not just patients with asthma, they're patients with asthma in a given subtype. Some have asthma that is triggered by infectious agents, others that are triggered by medicines that they take, others that are triggered by nothing observable. Some are associated with heart failure, some are not. The point is that there are definitely different subgroups of asthma, and now investigators are trying to identify the genetic basis of that. One other example of unsupervised clustering has been performed by my colleague. I'll show you her in a second. And the question that was attempted to be answered was, a patient has a given disease, breast cancer, and they want to look for a clinical trial that they might be able to enroll in. They have breast cancer, but the trials have all sorts of requirements. The patient has to be a certain age. One trial, the patient has to be a certain age, has a certain staging of their cancer. We call this eligibility criteria. And though there might be 60 or 70 different trials for breast cancer, and they all have different eligibility criteria, how is a patient who's looking to be part of that study, or a physician looking to find a study for the patient, able to narrow down the 70, 100, maybe 200 different trials? And so one thought was, well, maybe there are clusters of trials. The eligibility criteria sort of cluster, maybe there are trials for only young women, there may be trials for elderly patients, maybe there are trials for patients who failed therapy, maybe there are different clusters. And then based on the patient's own set of characteristics, their age, their staging, the medicines they've been on, maybe the cluster, they'll be able to be matched to a cluster of trials which is much smaller in number and gives the patient a chance to enroll. So this was performed by my colleague Chenhua Wang. Here she is, and they published a clustering paper where they showed that you could identify subgroups of clusters that would be able to be matched to a patient's attributes and make it much easier for a doctor or a patient to find an appropriate set of trials. Again, this is classic unsupervised learning. You load in as many attributes of the cluster, as many of the eligibility criteria has been mentioned, and let the machine see if it can figure out if there are different groups. So we've talked about supervised learning, classification, and predictive modeling. We've talked about unsupervised, that is associations and clustering. And we want to just mention a couple things about the limitations. First, the quality of the data is important. If you have bad data, you can't do data mining. And health data is notoriously inaccurate. It's very challenging. There are a lot of really smart people who are trying to figure out how to improve the data quality. One way around that is if you have enough data, if you have 500,000 patients, you can get around some of the inaccurate data. We did a study years ago on chronic kidney disease, and it ended up a lot of the patients were lacking the documentation that they had chronic kidney disease, even though they had chronic kidney disease. So using their data would have been inaccurate because many of the patients had not been noted to having an important condition. And if you were studying chronic kidney disease, you'd end up with inaccurate data. The other problem, of course, is overfitting. If you create a model on very few patients, the model is going to be specific for those few patients and generally will not be successful when applied to a larger group of patients who might have somewhat different characteristics. We call that overfitting. The model is just too fit to the sparse data. So clearly, the more patients, the merrier. And then lastly, just to make the obvious point that if you find an association through data mining, it doesn't mean that it's causal. The strengths of data mining are important. First of all, it's a completely different mindset. The mindset it basically flies in the face of the classic hypothetico-deductive model, where a scientist would say, well, gee, I know this, that, and this about a particular condition. I'm going to make a prediction or a model based on what I already know, and I'm going to supervise the machine to build a model based on that. We built a model on chronic kidney disease prediction. We know that the kidney performs certain functions. We'll tell the machine, look, here are the functions, here are the results of those functions, and you, the machine, build a model. Well, the data mining turns this upside down. It says, well, hold on a second. With all due respect, you don't know anything about anything. You think you know about treating peptic ulcers and giving heavy cream. That ended up, of course, being completely wrong. And we're going to tell you, we, the machines, are going to tell you what are important attributes. So just give us every attribute you can plug into the data set. Put in the zip code for chronic kidney disease prediction. Put in the patient's relative ages, the ages of their relatives. Maybe that will be predictive. Put in all the medicines they've taken, and we'll let us do the thinking. And that is the power of data mining. It really has no a priori assumptions, and it can find associations that otherwise would not have been looked for. Lastly, this is a little subtle, is that data mining will answer questions that will never be asked in a randomized controlled trial. That is to say, randomized controlled trials are so expensive, so difficult to assemble, that there are certain questions that would be of interest to all of us, that those questions will never be studied in a randomized controlled trial. Nobody's going to fund that study. Nobody's going to perform that study. So, a simple example might be asking, do patients with diabetes and gout do better on an angiotensin converting enzyme inhibitor or calcium channel blocker? And that's a question that we'd like to know the answer. How does gout alter the response of a patient with diabetes to those drugs? Well, it's an interesting question, and nobody's ever going to do the study. Nobody's going to take a huge group of diabetic patients with and without gout, divide them up, give them one drug versus another. That study can only be performed by data mining, where you have 100,000 patients with diabetes, maybe 5,000 have gout. You find match controls, and then you find out what medicines they're on, and you can actually attempt to answer that question. So data mining is the future of clinical research. Well, of course, we'll still have clinical randomized controlled trials. They're very important for establishing proof, but far more information is going to be obtained by data mining. And of course, to accomplish this, you need huge data sets, and that is in our future. I just wanted to mention, for those of you who are here at CUMC, we have our own database of millions of patients, and the data can be extracted from the data warehouse. I have a podcast on how to do that, so take a look at my Google channel. There is a group, a consortium called Odyssey, pronounced Odyssey, Observational Health Data Science Informatics. It's an international network, go Google them, of researchers and observational health databases. It's coordinated here at CUMC. Right now, there are 680 million, that's not a typo, 680 million de-identified patient records. Meds being taken, age, demographics, diseases. From all around the world, countries are donating, if you will, de-identified patient records. There's a common data model now so that all the records can be put into this database. And the number of questions asked is increasing exponentially, and anybody, literally, without needing a security clearance, can sit down with the proper access and perform clinical observational studies using this database. It's phenomenal, and again, you should go Google that and read about it. There are other data sources. You can scroll through these when you get a chance, and they're both databases and their terminology, descriptions of terminologies. This will help in any data mining activity or a data mining study you're interested in. So I'd like to finish by discussing briefly the fact that there really is a new discipline. It's called data science. It's interdisciplinary. It's about methods. It's about processes. It's about systems, how we extract knowledge. It's a new discipline. There are new departments. There are new training programs. There are PhD programs, postdocs, all sorts of ways to become skilled in data science, and it's really only possible, as mentioned, because of the incredible amount of data we now have, the cutting-edge algorithms that have developed, and the hardware, basically, that has been able to keep up with the need to store all that data. Thank you, and if you're interested in data mining and machine learning, I suggest you come and take a look at our Data Mining Institute here at Columbia and see what's up on their website. Thanks very much, and thanks very much.